brain imaging is to understand anatomy. So if you understand how different structures look on MRI and CT scan, then it becomes easier for you to detect pathology. And learning anatomy is not a one-day job. You have to keep looking at the MRI film, CT scan films repeatedly over the period of time. Once you see maybe at least 200, 300 MRI which are normal, then you will be able to understand that this is normal, because again, normal has so many subtle variations and you will always confuse it with some pathologies. But then maybe you see the report, or gradually you come to know that okay, this appearance is a normal. So in fact, it is much more difficult to confidently say that this MRI is normal rather than detecting at certain pathologies, because many pathologies are very easily seen and it is easier to say that okay, this is something which is abnormal, there is a tumor or there is an infarct. But when patient is symptomatic and still you have to tell that no, MRI is absolutely normal or CT scan is normal, that is much more difficult, and that needs you to see so many normal films of MRI and CT scan. I'm trying to explain some basic structures which are seen on MRI. Why I am taking this anatomy on MRI? Because they are much better seen on MRI compared to CT. I'll show you CT scan also after this, but try to look at all these structures on MRI films. We are starting from the base of the skull, that is from the inferior part, and then going superiorly. So from base of skull to the vertex. So this hypointense flow void, what you see here, which is marked with arrow, this is the appearance of vertebral artery. So for seeing artery, we usually do angiography, but even without angiography on routine MRI films, we can see the arteries. That is one advantage of MRI. So they are seen as hypointense or black structures without any signal in it. That is the flow void of vertebral artery, and this is normal vertebral artery on left side. This is the vertebral artery on right side. This is the cervicomedullary junction, because we are still at lower level, so the medulla has not come. This is cervicomedullary junction. Once we go one cut above, then you can see this appearance of medulla. Lateral medullary pyramids. This is the entire medulla oblongata. Here what you see is the flow void of vertebral artery in its petrous segment. So this is the vertebral artery, the medulla oblongata. As you go still above, what you can see is the 7th and 8th nerve complex. So this is the region of cerebellopontine angle. This is the CP angle. This is the canal, and here the 7th and 8th nerve, they courses through this canal and going inside. This is the inner ear structures. So the normal appearance of 7th and 8th nerve. The cerebellum, the left cerebellar hemisphere, the right cerebellar hemisphere. Once you go above, then you can see anteriorly, you can see the optic nerve. So this is the eyeball, the lens. You can see the extraocular muscles. This is the medial rectus, this is the lateral rectus, and this is the optic nerve. This is the retroorbital fat. These are the paranasal sinuses, the sphenoid sinus, the ethmoid sinus. Then you can see even the trigeminal nerve, which courses from here and goes to the Meckel's cave. So this is the trigeminal nerve. Then is the middle cerebellar peduncle. These are two paired structures which connect the cerebellum with the brainstem. This is the middle cerebellar peduncle, and this is an important site mainly to look for plaques of demyelination in cases of multiple sclerosis. The cerebellar vermis, the midline structure which fuses both the cerebellar hemispheres. As we go above, you can see the pons and the fourth ventricle, which is almost rounded structure. Always look for the diameter of the fourth ventricle and look for enlargement in cases of in patients who are having hydrocephalus. Transverse sinus, as I said, to see the arteries and veins, we need to do angiography or venography, but even on routine MRI, we can have some idea about patency of the arteries and veins. So here, the hypointense, again, wherever the blood is flowing, you will see it as flow void on routine MRI. That is markedly black or hypointense. So this is the normal flow void of transverse sinus. Here is the basilar artery. So both the vertebral arteries, they are joining to form the basilar artery. We saw the vertebral arteries downwards. You can see here the vertebral arteries are joining and then they are forming the basilar artery, which is seen here. So, once we go above this, then what you can see is the midbrain. So if you see the appearance differs of medulla, pons, and midbrain. So there's the midbrain, the cisterns around the midbrain. And you can see the flow void of posterior cerebral artery. You can see the flow void of middle cerebral artery. You should know the location where these arteries are situated. Once we go a little above that, this is a very important image where you see important structures, that is the different parts of the basal ganglia. So this entire part is called the basal ganglia. This part is known as the thalamus. The basal ganglia again has multiple parts which are I've shown it in different color here. So if you see this, this is the caudate nucleus. This part is the caudate nucleus, head of caudate nucleus. Then above that is the body and tail. But important thing is to look for is this head of the caudate nucleus. Then there is external capsule which is outside this. So this part is the external capsule. Then there is putamen, which is outer structure. Then there is globus pallidus, which is the inner structure. Then there are three parts of internal capsule. This is the anterior limb of internal capsule, which is seen here. And there is a genu of internal capsule, and there is the posterior limb of internal capsule. So if you see this fork-like structure, this is the anterior limb, genu, and posterior limb of internal capsule. And this part is the thalamus. So you should be knowing all these structures clearly. What is basal ganglia, what are the different parts of basal ganglia, and where the thalamus is situated. Then this is the region of pineal gland. So if you see any space occupying lesion in this region, it can be a pineal gland tumor, or calcification is common in pineal gland. So certain areas where you physiologically you can see calcification, like basal ganglia calcification can be seen physiologically in elderly patient. There can be pineal gland calcification. There can be calcification in the falx, that is the interhemispheric fissure, or sometimes even choroid plexus can show calcification. Pineal gland is the superior sagittal sinus. Just like we saw transverse sinus, this is the normal flow void of the superior sagittal sinus. Then corpus callosum, this is the genu of the corpus callosum. I'll show you the entire corpus callosum in the sagittal plane, where it is seen very nicely. This is the third ventricle. These are the frontal horn of lateral ventricles. These are the occipital horns of lateral ventricles. This is the third ventricle. Then you can see the straight sinus, again the flow void of straight sinus. And once you go above, then you can see the splenium of corpus callosum. The anterior is, this is genu of corpus callosum. This is the splenium of corpus callosum. It is a sagittal sinus again. It is a continuous structure, so you will see this flow void throughout all images as normal flow void of superior sagittal sinus. A central sulcus, the most important structure to identify, because this differentiates the frontal lobe from the parietal lobe. So whatever lesion is situated anterior to the central sulcus, it is in frontal lobe. Posterior to it is in the parietal lobe. This is the precentral cortex, this is the postcentral cortex, and as you know, these are the areas which are important for the patient's motor and sensory movements. So patient's motor senses and sensory. So whenever a lesion is situated adjacent to this in the precentral or postcentral cortex, then you can imagine that even a smaller infarct or small lesion in this part can cause significant symptoms to the patient and loss of movement also. Still, if we go above, then this is the interhemispheric fissure or falx. So this is all on MR. You can see all structures very nicely. You can see the gray white matter differentiation also much better on MR compared to CT scan. You can see here all this deep part is the white matter. This is the cortical gray matter. White matter looks more black on T2-weighted images. It is reverse. In brain parenchyma, whenever there is white matter, it looks more hypo-intense on T2-weighted. The gray matter, it looks more of a little bright than white matter. And what is markedly hyper-intense, that is all CSF. So this is the CSF in the sulci. You can see the CSF in the ventricular system also. Okay, so this is all about normal anatomy of brain on MRI, and same you can see on CT scan also. If I scroll through these images, you can see almost all structures which we saw on MRI on CT scan also. But the clarity of visualization of the structure is much less on CT scan compared to MRI, because the intrinsic contrast of MR is much higher compared to that of the CT scan. And that is why CT scan is not very useful, particularly in structures which are surrounded by either air or dense bone. So if you see here, okay, here you can see there is some hypodensity here. So it looks like Is it an infarct or is it normal? This is normal. This is just because of the dense petrous bones which are surrounding this structure. That is why it gives such kind of artifact on CT scan. So a small infarct in this region is difficult to identify on CT scan, but on MR it becomes very easy to identify. Similarly, you can even see some artifacts here also, which is hyperdense. So is it a hemorrhage? No, it is not hemorrhage, it is just artifactual. So particularly brainstem lesion, even sometimes the lesion which are in the cerebellum, CT scan is less useful compared to MRI. For lesions which are in basal ganglia or thalamus, you can see here all parts of basal ganglia, the choroid nucleus, the internal capsule, the thalamus, the globus pallidus and putamen, both may not be seen separately, but you can see the entire ganglion or capsular region. This is the sylvian fissure, the ventricles. So everything you can even identify on CT scan also. As I said, there can be subtle normal calcification in the choroid plexus, which is visible on CT scan. And this is the region of pineal gland. You can see the central sulcus also. You can identify it clearly on CT scan. The sulcus which goes most medially, this is the central sulcus. Here is the central sulcus. So anterior to this is the frontal lobe, posterior to this is the parietal lobe. So you have to identify all structures on CT scan also. Looking certain structures on coronal images, because certain things which are better visualized on coronal imaging plane, like optic chiasma. Both the optics now they join together and form this optic chiasma, which is better seen on the coronal imaging plane. Then this is the internal carotid artery. You can see both the sides, the normal flow void of internal carotid artery, and you can see the pituitary stalk and the pituitary gland. So this is the pituitary gland which connects the pituitary gland with the brain parenchyma. That is the pituitary stalk. Then on sagittal plane, you can see the superior sagittal sinus, which is a continuous structure going from here to here. I'll show you it in MR venography again. This is the straight sinus. Here is the cerebellum. This is the cerebral hemisphere. You cannot make out, this is almost midline cut. So you cannot make out whether it is right or left because they are identical. Then this is the corpus callosum. This entire structure is corpus callosum. Look for its normal formation. If there is some part is absent, then can be hypoplasia or dysgenesis of corpus callosum. This is the superior sagittal sinus. This is the bones. This is the midbrain. And this part is cerebellum. This is medulla oblongata. And here is the cervical spinal cord. So this is the cervicomedullary junction. Again, pituitary gland, you can see it in the pituitary fossa, which is surrounded by sphenoid sinus. You can see the gland very nicely. And on a closer look, you can see different parts of corpus callosum. This is rostrum of corpus callosum. This is genome. This is body. And this is splenium of corpus callosum. So you can see all parts of corpus callosum clearly on MRI. This is the pineal gland. And this is a small rounded structure, is the mammillary body. And here is the cerebral aqueduct. This is a small communication between the third ventricle and the fourth ventricle. This rhomboid shaped structure is the fourth ventricle, which looks round on axial images, but on sagittal you can see it as a triangular structure. This fourth ventricle, this cerebral aqueduct. These are the MR angiography image. The advantage of MRI is that you can get all information about the brain vessels without giving any contrast or without doing any intervention. So this is just like different specific MR sequence. Just like other sequences, the patient is placed inside the magnet and with a special acquisition which takes about 6 to 7 minutes time, we get all information about the vessels of the brain. So you can see both the internal carotid arteries. This is the middle cerebral artery. It's M1 segment, M2 segment, M3 segments. It's all cortical branches. Same way here. These are the both vertebral arteries, the basilar artery, the right posterior cerebral artery. On left side, the posterior communicating artery is more prominent and the posterior cerebral artery is predominantly filled through the anterior circulation. So this is known as the fetal origin of left PCA, where posterior communicating artery is prominent, which is supplying the posterior cerebral artery. Here is the anterior cerebral artery, the A1 segment. This is the anterior communicating artery, a very short artery, and these are both the anterior cerebral arteries, right and left. on left side, the A1 segment of anterior cerebral artery is hypoplastic. This is again very common. So many of the times both anterior cerebral arteries are filled through one-sided vertebral artery instead of both. So if this patient has occlusion of this internal carotid artery, then patient will develop stroke, which is in the region of both the ACA and right MCA, not just one ACA. So keep this in mind. There can be hypoplastic vertebral A1 segment of anterior cerebral artery, and both anterior cerebral arteries can be filled through one-sided circulation. And this anterior communicating artery, though it is a small artery, this is the most common side of aneurysm. So remember this to look carefully at the anterior communicating artery for any aneurysm. Similarly, not just brain, we can also do angiography of neck with the help of MR, with same thing, without any contrast, just with a specific MR sequence where you can see this is the arch of aorta. Here is the brachiocephalic artery. This is the right common carotid artery, which is dividing into the internal and external carotid arteries. This is the right vertebral. Same way on left side, this is left internal carotid, this is left external carotid and its multiple branches, and the left vertebral. This is the left subclavian artery. So you can see all these structures very beautifully without any intervention or without any contrast injection with the help of MRI. It is very much important for you to know the arterial territories. So if you see an infarct or a part of ischemia in one part of brain, then you should be knowing that by which arteries it is supplied. Then it serves two purposes. One is it can tell you that in which territory, which arterial territory the infarct is, and you can also imagine that which could be the other areas where infarct can be there. For example, if there is an infarct of posterior cerebral artery territory, then if you see infarct in that certain parts of PCA territory like posterior temporal occipital lobe, the thalamus is also supplied by the same PCA. So always look more carefully for the thalamic infarct also. So again, starting from the base of the brain, this part is supplied by the anterior cerebral artery. The MCA has a very large circulation, and the anterior part of temporal lobe is supplied by middle cerebral. The posterior part of temporal lobe is supplied by the posterior cerebral artery. While posterior fossa, which is cerebellum, and brainstem, these are supplied by the posterior circulation, that is posterior inferior cerebellar artery, the inferior part of cerebellum, which is a branch of vertebral artery, and pons is supplied by the basilar perforating arteries, which arise from the basilar artery. Once we come above, again, this is the territory of anterior cerebral. The green is all middle cerebral. This is posterior cerebral. You can see a part of the midbrain, which is known as the cerebral peduncle, which joins the brain with the brainstem. It is supplied by the posterior cerebral artery. While here, it is supplied by the superior cerebellar artery, which is a branch of basilar artery. Well, again here, this is the posterior cerebral artery territory. As we come above, the large part is supplied by the middle cerebral. Almost entire cerebral hemisphere except the paramedian frontal lobe and the posterior temporal and occipital lobe. The rest all is supplied by the MCA. The entire basal ganglia is supplied by the MCA. Maybe a part of caudate is sometimes supplied by the ACA. And this is the thalamus. The thalamus has multiple arterial supply, but most of them are branches of the posterior cerebral. So whenever there is an infarct of posterior cerebral artery in posterior temporal or occipital lobe, look for the thalamus, because the thalamogenicular artery, the choroidal arteries, the lateral posterior choroidal arteries, all these are coming from the posterior cerebral artery and supplying the thalamus. So look for infarct in this region also. As we come above, again, now there are only three arteries, the ACA, the MCA, and a little bit by posterior cerebral artery. So after these arterial territories, MR venography, again, this is similar to the angiography. This is a specific MRI sequence which gives us details about the venous sinuses. The venous sinus is just like veins in body. They are draining the blood which is supplied by the artery, right? And you can see this is the superior sagittal sinus. There are so many sinuses, but some of them are not very much important. You should know at least superior sagittal. These are both transverse sinuses. This S-shaped or the curved is the sigmoid sinus. This is the sigmoid sinus, and this is the internal jugular vein. The sigmoid sinus, it drains into the internal jugular vein. And the straight sinus, and these are the two internal cerebral veins which form the vein of Galen, and then it drains into the straight sinus. So this is how the venous drainage is there. Many of the times the anterior part of the superior sagittal sinus can be hypoplastic, and in those cases this cortical branches are more prominent. So it is possible to have hypoplastic anterior part of superior sagittal sinus normally with prominent cortical veins on either side. What is the importance of MR venography? Whenever you see there is a filling defect in part of this sinuses, or when you see a part of sinus is blocked, when you don't see this sinus at all, this is venous thrombosis, which is a cause of patients' severe headache, and many of the times it can even cause venous infarcts also in brain. So you should know about normal brain anatomy. You should be able to identify at least some arteries and venous sinuses. What is the role of CT and MR for brain? CT, as we know, it is the full form of CT scan is actually initially it was termed as the CAT scan or CAT, which is computed axial tomography or computed tomography. It is the cross-sectional imaging. It is helpful for evaluation of bony as well as soft tissue pathologies, and this is a real breakthrough in the field of radiology. Before CT scan, there were very limited applications of radiology, but with CT and MR, it is completely changed. MRI has much more advantages over CT scan. It has very high intrinsic contrast, so you need not to give intravenous contrast for differentiation of certain structures, which is the case for CT scan. You can scan in any orthogonal plane. The images, whatever you are seeing in CT scan, they are always obtained in axial plane, and then they are reconstructed in different planes. So the sagittal and coronal, what you see, all those are the computer generated images based on the data which is collected from the axial images. While in MR, you can directly obtain the sagittal, coronal or oblique images. There is no artifact because of bone or air. So as I said, the posterior fossa structures or brainstem, they are much better seen with the help of MR. There is no radiation, so MR is absolutely safe even for pregnant patients because there is no radiation. There's no biological hazard. MR can be repeated multiple times without any fear of any kind of damage to the patient. For CT scan, if you want to do it very frequently, it can result in some radiation exposure. So we always have to check for the benefit versus damage ratio. In patients who are already having malignancy, there is no harm in doing CT scan even every month also, because we are more concerned about the patients, because patient is going to die of malignancy and not of the radiation. The radiation hazard is there, but it is not that severe that it can endanger patient's life. There is excellent tissue characterization, and as I said, we can do blood flow imaging with the help of MR. So in neuroimaging, where do we use CT scan? CT scan is used primarily imaging modality to exclude hemorrhage in patients of stroke. So the role of CT scan is to exclude hemorrhage. If there is infarct, the CT scan may or may not show it. CT scan usually shows infarct almost about 24 hours after the onset of symptoms. Before that, CT scan will be normal. But as the treatment for infarct and hemorrhage are completely different, and CT scan is much faster, easily available, cheaper. So many of the times patient is subjected to CT scan. So if CT once tells that there is no hemorrhage, so even though the report is normal, when the patient has hemiplegia, it is expected that there could be some infarct, which is the result of patient symptoms, and patient can be treated accordingly. It is useful for evaluation of head injury, particularly to see for fractures and bony details. So it shows details of hemorrhage also, parenchymal contusions and subdural extradural hemorrhage, but that will be seen with MRI also. But details of fracture, this is something where MRI fails. It is seen only with the help of CT scan, where you can see all details of fractures. It is good to see for the follow-up of the hydrocephalus when we just want to see the ventricular size, or in many patients who have subdural hemorrhage, because CT scan is much faster and cheaper. What are the applications of MR? For neurology, stroke, for any kind of stroke, MR is the treatment of the modality of choice. The tumors, for infection, for congenital malformations, and for selected cases of trauma. So for all these, MR is very much important. Nowadays, it is almost like neuroimaging is equal to MRI. There is no neurology or neurosurgery possible without the help of MR. And it has largely replaced CT brain, except in cases of head injury and when there is suspected intracranial hemorrhage. So what are the indications of MRI? Almost everything, from trauma to congenital anomalies to dementia, hydrocephalus, to see for the cranial nerves, to see for infection, demyelination, for everything, MR is much superior. What are the tools in neuroimaging? As we discussed in NSK, there are sequences like T1, T2, PD, which were the main sequences in NSK. In neuroimaging, there are many more sequences. So it is important for us to know what we are looking for so that we can plan our sequences accordingly. We can't do all this in each and every patient, because otherwise patient has to lie down in MR machine for more than 1 hour, which is not possible. So there are some basic sequences like T1, T2 flare, the diffusion weighted ADC, the SWI, which we take for every patient. Then the other sequences like angiography, venography, the perfusion or CSF flow mapping or spectroscopy, they can be obtained as per the requirement of the patient. So it is important to know the indication for which the MRI is being done so that we can plan on the sequences. So for the head injury, please remember, plain X-ray alone has no role in the evaluation of head injury. So don't ever send a patient with head injury for an X-ray of skull, because it is completely useless. Even if you see a fracture on X-ray skull, it does not suggest anything. The patient's brain may be absolutely normal, or there may not be any fracture and there could be still a large parenchymal contusions or subdural hemorrhage, which are life-threatening. So X-ray, whether shows fracture or not, it does not make any difference to the patient's management. So there is no role of plain X-ray alone. Why initially people used to do X-rays? Because CT scan was not available, or in the era of single slice CT scan, where CT scan used to miss certain linear fractures. Now it is not the case. With multi-slice, it can detect even the smallest of fracture also. So CT is gold standard, and it should be the primary modality for all patients who have head injury. It shows all the pathologies like extradural hematoma, subdural hematoma. Like here, this is the extradural hemorrhage. Hemorrhage is seen as hyperdense or bright on CT scan. The terminologies you should be familiar. In CT scan, it is hyperdense. In MRI, it is hyperintense. In CT scan, it is hypodense. In MRI, it is hypointense. Same way for sonography, the terminologies are different. They are like echogenic or anechoic. So you should know these terminologies whenever you describe the pathologies or describe the structures on different imaging modalities. So when it is biconvex, this is the appearance of extradural hemorrhage. Usually it is associated with a skull vault fracture. This is the appearance of subdural hemorrhage. Again, you can see the hyperdense, but it is concavo-convex. So this is subdural hemorrhage. This is extradural hemorrhage. Extradural, usually it follows the suture margins. The subdural can go through almost entire cerebral convexity also, and this is the appearance of parenchymal contusion. So all these are the common pathologies in patients of head injury. So now with the multi-slice CT, we can even detect a very small contusion like this. A small area of blood in the brain parenchyma can be detected with the help of CT scan, and there is a small focus of air. So whenever there is an intracranial air, always suspect there is almost always a fracture somewhere, either in the skull vault or in the base of the skull, where which is in relation to the paranasal sinuses. From there, air can come inside the brain parenchyma. So a small air focus, a small area of contusion, all seen very nicely with CT scan. Even there is a focal hyperdensity in one of the sulcus. If you see this, just all the sulcus are filled with fluid except this one, which is filled with blood. So this is a focal subarachnoid hemorrhage. So all these can be detected with the help of CT scan. And as I said, CT scan gives all excellent details of fracture. There's a depressed fracture with multiple linear components of the fracture, and you can get everything, all minutes of details of the fracture with the help of CT scan. When the hemorrhage becomes chronic, then it becomes hyperdense to hypodense. So this is the appearance of subacute to chronic subdural hemorrhage. This is the ventricle. For head injury, as I said, CT scan is useful. But when do we do MR? When CT scan is normal, like here, a young patient who has significant symptoms, patient was unconscious and CT scan was normal, then MRI can help in detecting certain subtle contusions like here. There is a contusion in thalamus, there is a contusion in the splenium of corpus callosum. There is a special sequence known as susceptibility weighted imaging, which is extremely sensitive for any smallest of focus of blood anywhere inside the brain parenchyma. So this can detect these subtle contusions which are not even seen on CT scan, and these are known as the diffuse axonal injury. When the contusions are deep-seated in the deep cremator nuclei or corpus callosum or brainstem, then it is known as the diffuse axonal injury, and this is the appearance of diffuse axonal injury which is seen with MR. So when CT scan is normal or CT scan is not showing significant contusions which can explain patient's significant symptoms, then we have to do MRI to see for the diffuse axonal injury. For stroke, as I said, this is the appearance of acute stroke or acute infarct, but again this will be seen almost 24 hours after the stroke develops. This is with contrast, there is some enhancement, so this suggests that already reperfusion has started. So CT shows infarct but usually later, while MR it shows infarct very early. For infarct in the cerebellum, as I said, this is the superior cerebellum supplied by the superior cerebellar artery. This infarct will not be seen on CT scan, and you have to do MR to see this kind of infarct. A small infarct in medulla, like here, a very small infarct, but when it involves medulla, it can present with significant symptoms of cranial nerve palsies, and you have to do MRI to detect such kind of small infarct. So MR, there is a special tool which is known as the diffusion weighted images, which detects infarcts very early, usually within a few minutes after the infarct has occurred. So if you see the CT scan, a 70-year male presented with right-sided weakness, CT scan was normal. It was not showing any infarct. Even the routine MR images, like this is the T2 weighted image, it looks normal. There is no infarct seen on T2 weighted. But if you look diffusion weighted, you can appreciate that these are the areas of infarct. So this is the hyperacute infarct, which has probably occurred maybe just about an hour or 2 hours before. And if we detect this, we can save the patient's further complications. We can reduce the morbidity, the thrombolysis can be done, and patient can be saved of probably lifelong hemiplegia. So this is the utility of diffusion weighted. A young patient, 22 years, even the MR looks normal, routine MR, but if you see diffusion weighted, you can see there is an acute infarct in the region of Sylvian fissure. So there is an insular and basal ganglia infarct, which is still hyperacute. This patient had tuberculous meningitis, and that is why he developed such kind of infarct. Otherwise, in young patients, it is not very frequent to have these large infarcts. When patient has multiple infarcts, like here, elderly patient 68 with multiple chronic infarcts, we are not sure which one is acute. But diffusion weighted will show that out of all these chronic, there is a small focus which is acute, and that is why patient has symptoms which are fresh. We can even do CT perfusion, which is CT perfusion is done with the help of intravenous contrast, and this helps in differentiating areas of ischemia from areas of infarct. So this part of brain is still reversible. It is ischemic, but it is not infarcted. So if we do some intervention, then this patient can be saved. So this area can be prevented from going into infarct. Infarct is irreversible. Once a brain tissue is infarcted, it cannot be regenerated. But ischemic brain tissue can be, it is the salvageable brain tissue. Once infarct becomes chronic, it results in gliosis, like here. This is markedly hypodense, becoming like gradually like the CSF. So this is the appearance of chronic infarct with gliosis. There is loss of volume. So you can see the ventricle is also dilated. Here is the chronic infarct in the basal ganglia with resultant gliosis. Coming to the hemorrhage, as I said, infarct appears hypodense, hemorrhage appear hyperdense. So this is the criteria of hemorrhage in the left basal ganglia and thalamic region extending to left temporal lobe. In here, there is a focal hemorrhage which is extending in the ventricular system. This is the intraventricular and intraparenchymal hemorrhage. So CT scan, it shows hemorrhage immediately. It is not like infarct. Infarct is seen almost after 24 hours. Hemorrhage will be seen immediately as soon as it occurs. MRI also shows hemorrhage immediately. So, and what is the superiority of hemorrhage? MRI, it can detect hemorrhage, but the difference is MRI can differentiate how old the hemorrhage is, whether it is less than 24 hours, 1 to 3 days, 3 to 7 days, more than 7 days, because all these different time duration have different kind of hemoglobin inside that blood. And that is why their signals are different on T1 weighted and T2 weighted. It's a little complex, but at least you should know that MRI can differentiate the exact age of hemorrhage, whether it is hyperacute, acute, subacute, or chronic, which is not possible for CT scan. CT scan detect acute hemorrhage, it can detect once it has resolved, that is chronic hemorrhage, not the in-between phases. Many of the times when there is an infarct, there will be reperfusion, and then it can result in hemorrhagic areas within the infarct. So you should be careful for telling. If patient has any previous investigation available, then look at the previous examination also, where there could be an infarct which has resulted in hemorrhagic transformation because of the reperfusion. So in short, MR is superior to CT in diagnosis of hyperacute infarct. MR is as sensitive as CT in diagnosing acute intracranial hemorrhage, but CT scan is currently widely used to exclude hemorrhage before doing thrombolysis in patients of stroke. Coming to a few other pathologies like epilepsy, many patients who present with intractable epilepsy which are not responding to treatment, MRI is done. It can detect so many abnormalities. I'm not going in all details because again it will be all these are a separate lectures of maybe 1 hour each. But here you can see the hippocampus. If you compare both this, the left hippocampus is smaller compared to the right side, and this is known as the mesial temporal sclerosis. With different MR sequences like T2 relaxometry and volumetry, we can even measure the exact volume. We can see the signal intensity, and this clearly shows that there is a left-sided hippocampal atrophy. Infection, for all infection, MRI is the modality of choice. For meningitis, cerebritis, abscess, tuberculous infections, like here, this is a large tuberculoma. You can see there. And this is one condition where contrast is usually recommended. So we have to do intravenous contrast in MRI also to detect the infection in better way. So this is the appearance of tuberculoma on MRI. Here is the tuberculous meningitis. You can see enhancement in the basal cisterns and also along the leptomeninges with a few small tuberculoma in the brain parenchyma. So this is all CNS tuberculosis. Again here, there is a peripherally enhancing lesion on CT scan. That is the appearance of tuberculosis on CT. But on CT, it becomes difficult sometimes. Even metastatic lesions, they also look same. So MRI helps over CT scan in differentiating tuberculoma from metastasis. Right. This is the appearance of neurocysticercosis. Again, it looks like a tuberculoma, a peripherally enhancing lesion, but there are some differences in the MR characteristic, and that is how we can differentiate that this is a neurocysticercosis. On CT scan also, it is peripherally enhancing with a small central scolex. Again, it is important to differentiate both these because the treatment is completely different for tuberculosis and cysticercosis. Here, there are again multiple tuberculomas, and some of them are showing diffusion restriction. So this is the appearance of abscess. So whenever there is a brain abscess, it is seen as just like infarct. It will show diffusion restriction, but it will show peripheral enhancement. And this is the classical appearance of multiple tuberculoma with a focal area of tubercular brain abscess. Another important condition is multiple sclerosis, where you see multiple areas of demyelination in the brain. Again, MRI is the modality of choice for detection of this plaques of demyelination. If you see this rounded and oval hyperintense areas in the white matter of brain bilaterally, as well as multiple areas in corpus callosum. And this is the classical appearance of multiple sclerosis. For tumor imaging, a condition like a young patient, 7 year, there is a large glioma in the brainstem. If you remember our normal appearance of bones, it looks like this, but here it is replaced by a hyperintense lesion with its expansion and enlargement, causing compression of the fourth ventricle, and this is the pontine glioma. While here is the butterfly glioma, that is the glioblastoma multiforme, or GBM, or high-grade glioma, which is extending from one cerebral parenchyma to the other parenchyma through the corpus callosum. So it is the transcallosal extension of the tumor, and it is known as the butterfly glioma. Pituitary adenoma, many patients who present with a visual complaint because there is a large tumor in the pituitary gland and it is causing compression of the optic chiasma. It is also encasing the internal carotid artery, and all these details are important for the surgeon to know. So they have to get an MRI done before operating the patient. Many patients who present with complaints like galactorrhea, and when you do MR, you can see a small, very tiny, about hardly 2 millimeter size lesion in the pituitary gland, and this is a small microadenoma which is responsible for patient symptoms. So MR is so sensitive that it can detect even such a small 2 millimeter tumor also. What is new? There are different things like MR spectroscopy. Just you should know about these things. Maybe if it is asked in your exam that what are the recent advances or newer things which are done in neuroimaging, then you should know that there is something like MR spectroscopy where it detects different metabolites in the brain parenchyma. These common one are the NAA or N-acetylalanine, then there is choline, then there is creatine, there is lipid and lactate. So depending on the this peak, for example, here choline is higher, Na is almost absent. So this suggests that there is some tumor where the normal brain parenchyma is lost and it is replaced by choline, higher choline. So that suggests a tumor. Many of the times when there is some doubt, for example, a lesion like this, is it a multiple tuberculoma or it is a metastatic lesion? Because this patient also had prostatic malignancy. But when we did spectroscopy, it showed that choline was very less. Instead, lipid was very high, and this is a characteristic of tuberculoma. So if you know the characteristic of different lesions, then you can detect this, that whether it is a TB or a metastatic lesion. Similarly, MR perfusion, just like what we saw CT perfusion, we can do MR perfusion also with intravenous contrast, and we can detect areas of ischemia from the infarct depending on the various blood flow patterns, whether blood is going fast and then there is increased feeling and increased washout. Similarly, for certain tumors also, we can do such kind of perfusion, which gives us the characteristic of the tumor, whether it is a benign tumor or a malignant tumor. Lastly, one more latest thing is the DTI or diffusion tensor imaging or fiber tractography. We used to learn different fibers of brain in our anatomy, and this detects those fibers clearly. You can see the different cortical fibers which are situated in the brain with the help of MRI. You can see the different fibers. You can even see the relation of the tumor with the fibers, so that the surgical approach can be planned based on this. All these are three-dimensional images, so the surgeon can plan from which he should gain entry to the brain so that he does not damage to certain important fibers, so that patients other senses are not lost after the surgery. Similarly, there is a functional MRI, like here, this is one example of MRI which is done with left hand finger tapping. So when the patient is placed inside the gantry, patient just moves his or her finger of the left hand, and these are the areas of brain which gets activated. So this suggests that this part of brain is responsible for patient's left hand finger movement. Similarly, if we move toe, then the areas which are important for the leg or toe movement, that will become activated. So that can be detected, all these can be detected with the help of MRI, particularly useful for a tumor imaging, like here. For example, at present, patient may not have any weakness because the area which is responsible for hand movement is spared. But when this tumor will be removed, it will be removed with some margin around it, about 5 millimeter margin. So if they remove this tumor with 5 millimeter margin, the patient's hand movement might be compromised after the surgery. So that can be even explained pre-operatively to the patient, and the surgeon can decide so many their operative plans based on this. So this is known as the functional MRI. Similarly, the function of visions, function of speech, all these can be detected with very advanced MRI techniques. Thank you so much. So this is all about neuroimaging, which is useful for you. Are there any questions regarding this?
Thank you so much, sir, for sharing the immense knowledge about the MRI. I would ask students to ask questions in the chat box.
I think we have got some time. Should we take yesterday's spotters also?
Yes, sir, sure.
Do you have any back-to-back presentation at 12, or if
Uh, no, we don't. So we can,
it is okay if we extend for
yeah,
5-10 minutes more?
yes, 5-10 minutes would be okay, sir.
Okay. What is the difference between CT perfusion and PET scan? Okay, both are completely different. PET scan is, I didn't cover PET scan because PET scan is positron emission tomography, which is done on a completely different machine. There is a dedicated machine for that. There is one substance called the FDG, fluorodeoxyglucose, which is injected in the patient, and that gets deposited in areas where there is high cell turnover. And high cell turnover is seen usually in malignancy and in infection. So those areas will concentrate that FDG, and that will be detected with the help of PET-CT scan. So that is the PET scan, which is useful for whole body imaging, for tumor imaging, many of the times infection imaging, sometimes for brain also, but its role in brain is less compared to its role in whole body. While CT perfusion is just like routine CT scan with intravenous contrast, which detects which part of brain takes up more contrast and retain it for longer time or release it soon. So usually the malignant lesions, they pick up contrast very early and they release it also very early. So depending on these things, we can differentiate whether the tumor is benign or it is malignant. Between MRI perfusion and fMRI. fMRI is functional MRI, what I showed you, like with finger tapping, or which part of brain gets activated. And perfusion MRI is with the help of intravenous contrast, which shows which area of brain is perfused more. So fMRI is done with patient's active involvement. While for perfusion, patient just has to lie down. We just inject contrast, we do a spatial MR sequences. While for fMRI or functional MRI, we have to instruct the patient, okay, move your hand, stop moving your hand, or move your leg, stop moving your leg, and at that time the activity in the brain is detected. Can we differentiate it between age-related white matter changes and leukomalacia? There are no as such age-related white matter changes. Normally, even with age, the white matter should remain white only.